Hello and welcome everyone. We have organized a small CME today and the topic is management of hypertension. Dr. Agha, Rehan, Abbas. I am here before you. I am only going to take 2 minutes of your time to introduce who all doctors are here. My beloved aunt, Dr. Najafi is here. She is an assistant professor in forensic, associate professor, sorry. Please accept my apologies. So she is associate professor, currently working with CMR College of Medical Sciences. She is ex-medical superintendent of Sarojini Devi Eye Hospital. Accompanied with her is her son, Dr. Amaan Zaidi, who is a resident of emergency medicine at KIMS Gachibowli. Accompanying them is my beloved wife, Dr. Mahek Fatima, who is currently taking a fellowship in Gynec and Ops from Fernandez Hospital, Bogolgunta. And we have other dignitaries, my dear friends, Dr. Ravikiran, Dr. Chaitanya, Dr. Abbas, Dr. Sakcham, and Dr. Nishat as well here. We'll be going very slow. Sorry for that. There is no rush today because there are only few of us. The first topic will be Hypertension, the Invisible Pandemic by Dr. Najafi, and I'll just hand over the dais to her. If you could please come here, ma'am.
I am extremely happy that Dr. Rehan and Dr. Mahek, they are holding a small CME in their clinic for the first time. This is a new concept in clinics and we want to take it forward to other hospitals too, where all young and enthusiastic doctors can take part and enlighten us with all the new concepts in medicine. So, I want to just say brief about hypertension. As you all know, hypertension is a sustained, continuous and increased. So it is a continuous, sustained, increased arterial blood pressure, and we can say it is a global pandemic because so many of us do not understand what hypertension is, local people, because they are not related to medicine. So we have to enlighten people about it. There are two types of hypertension: essential hypertension or primary hypertension, and secondary hypertension. And which is this thing, primary hypertension, it is comes over a period of time, and it is most of the time it is sometimes genetic, sometimes lifestyle based, and sometimes age related. And secondary hypertension, it is having other medical comorbidities like kidney problems, thyroid problems, and other are drug induced too. So what we know about hypertension is it is a global pandemic. It kills many people all over the world, and it is more common in our country because most of us do not know where to start our medication. So what we say is normal blood pressure should be around 120 to 180. But many times people land up in crisis because they don't know the modalities of treatment and the lifestyle changes. They start consuming more salt, more everything like processed foods and all which is rich in salt. So they land up with hypertension. And in our community here, people are always busy eating during Muharram and Ramzan. So post Ramzan and post Muharram, we find many morbidities in our area. So what are the different types I have told? So how do you stage a hypertension? It is just elevated or phase 1, stage 1, stage 2 and hypertensive crisis. If it goes beyond 180 and 120, we name it as hypertensive crisis. And this is the worst situation where any individual will land up with MI or kidney damage or any other end organs damage, including brain. Most of the cases which comes to our institute in Usmania used to be CVA or acute kidney damage. So from this we have learned that it is a very global emergency and other doctors will tell you how to deal with it. And there are other conditions of hypertension which is related to pregnancy. In pregnancy also there are two types of hypertension. One is chronic, which the individual has before being pregnant, and the other is gestational hypertension, which comes after 20 weeks of gestation. And another management of malignant hypertension is the utmost topic all over the world, where you can save an individual, otherwise he'll land up either with hemiplegia or paralysis or severe MI or kidney damage. So our new young and doctors, they will brief you about all the other modalities. Thank you.
Now we have Dr. Amaan coming to explain about hypertensive emergencies versus urgency.
So hello, good evening everyone. I'm Dr. Amaan Zaidi. So I'm an emergency physician and a diabetologist. I'm currently working as an emergency physician at KIMS Gachibowli, and I own my own hospital at Maulali, by name Maulali Hospital, and I'm also a team member of Fatima Multispeciality Clinic with my big brother Dr. Rehan and Dr. Mahek. So thank you for inviting me for this CME, and I welcome all of you here to this wonderful gathering here at Fatima Multispeciality Clinic here at Darul-shifa. So I'll be speaking a few words on hypertensive crisis, which includes hypertensive emergencies and hypertensive urgency. So let's start from the basics. What exactly is blood pressure? What is hypertension? And what are the types of hypertension? And lastly, I'll be speaking a few words on the management of hypertensive crisis. So we have heard people telling when someone have hypertension कि भाई उसको BP है या इसको BP आ गया, तो भाई लोग BP रहता सबको. If someone doesn't have blood pressure, that guy is dead. वो लोग बोल सकते कि जो सो बंदे को BP ज़्यादा है या वो बंदे का BP बढ़ के है. तो basically hypertension is having high blood pressure. So what exactly is blood pressure? So blood pressure is the pressure which is exerted by the column of the blood over the walls of the artery is defined as blood pressure. So hypertension basically is having high blood pressure. So my topic for today is hypertensive urgencies and hypertensive emergencies, which are due to prolonged hypertension, long-standing hypertension. Let me tell you the types and the causes of hypertension. So basically there are two types of hypertension. Primary hypertension, as my mother have already told you people, and secondary hypertension. Yeah. So primary hypertension have a positive genetic history, like the family people have hypertension, or it may be because of their lifestyle and their life choices basically, and it doesn't have any primary reason to it. Coming to secondary hypertension, it has no family history, and there are some causes to the secondary hypertension, like exogenous causes like taking a lot of corticosteroids, OCPs, cocaine, and black licorice. Renal causes including AKI and CKD, and also including glomerular nephritis, and also unilateral or bilateral renal artery stenosis, and some mechanical causes like aortic coarctation and OSA, and endocrine causes like Cushing syndrome, pheochromocytoma, hyperthyroidism, hypothyroidism, hyperparathyroidism, and also sometimes in pregnancy, which is also called as gestational hypertension. So coming to the pathophysiology of hypertension, so basically because of any of the above reasons, there are three reasons because of which hypertension develops. First being defect in the renal and the sodium hemostasis, which causes an increase in the sodium excretion, which causes sodium and water retention in the body, which increases the plasma and also increases the extracellular fluid volume, which thereby increases the cardiac output, thereby causing hypertension. Second is causing functional vasoconstriction, which increases the vascular reactivity, thereby increasing the total peripheral vascular resistance, thereby causing hypertension. And thirdly, there are some defects in the vascular smooth muscle growth and its structure, which increases the vascular wall thickness, thereby increasing the total peripheral vascular resistance and causing hypertension. So this is the basic pathophysiology behind the hypertension. So coming to our topic, so what exactly is hypertensive emergency and hypertensive urgencies? So a hypertensive emergency can be defined as having blood pressure of greater than 180 by 120 with signs of any end organ damage. That is hypertensive emergencies. So hypertensive urgencies are having blood pressure greater than 180 by 120 but without any signs of end organ damage. And the third one being accelerated hypertension, also called as malignant hypertension. So high blood pressure more than 180 by 120 with signs of retinal hemorrhage with or without papilloadenoma. So what is the pathophysiology behind the organ damage? So basically there are four reasons behind the damage to the organs. First one being the vascular damage, which is due to the mechanical stress. Second being the activation of the RAS mechanism, which is renin-angiotensin-aldosterone mechanism, which causes a widespread vasoconstriction with the expression of inflammatory cytokines. Thirdly, there is damage to the cell walls and the organs due to the oxidative stress, which is by the reactive oxygen species. And fourthly, there is an endothelial dysfunction, which is due to the excessive vasoconstriction and activation of the coagulation cascade. So what are the organs which are damaged due to high blood pressure? So there is a mnemonic for it, which is bark, brain, arteries, retina, kidney and heart. In brain there is a stroke which may be ischemic or hemorrhagic, or it can be hypertensive encephalopathy. In the arteries there is acute aortic syndrome including aortic dissection and also preeclampsia or the HELP syndrome. Thirdly, retina, it may be grade 3 or grade 4 retinopathies which involve the retinal hemorrhage or also papilledema. Fourthly, kidneys, which can be acute renal insufficiency like AKI or thrombotic microangiopathy. And fifth being heart, presenting as MI or acute pulmonary edema. So this hypertensive urgencies and emergencies should be managed so that the hypertensive urgency doesn't convert into hypertensive emergencies. So prompt management of hypertensive urgency and emergency is the foremost thing which we have to follow. And me being an emergency physician, I see every day 2 or 3 cases, every second or the third case which comes to the emergency is because of hypertension. So what are basically the clinical symptoms with which the patients present to the emergency? So general symptoms including sweating, pallor, flushes, tinnitus, epistaxis and fear of impending death and also palpitations. So if there is a particular system involved, suppose we take MI, So those symptoms will be palpitations, arrhythmias, chest pain, dyspnea, and presenting with pulmonary edema. And in any CNS causes, it may present as headache, nausea and vomitings, blindness, seizures and coma. Any kidney issue may present as oliguria, hematuria, proteinuria, and any electrolyte imbalance, uremia or azothemia. And malignant hypertension can present as flashes and scotoma with sudden onset of blindness. So how do we approach to a patient of hypertensive urgency and emergency? So firstly, you have to take a complete history of the patient. Secondly, do a thorough physical and a vital examination of the patient. Then ask for the investigations to rule out any particular organ damage. And fourthly, we'll see about the management of the hypertensive urgencies and emergencies. So history taking. So ask for the symptoms like any headache, blurring of vision, chest pain, back pain and dyspnea. And also ask for any associative symptoms. Ask for the comorbidities of the patient. And ask for the duration of the hypertension, and also ask for the medicine compliance or any sudden or abrupt stopping of any blood pressure medication. Ask for any illicit drug use, smoking or alcohol history, and also ask for any other medication which you have taken in a recent while, and also ask for any head trauma. So physical examination, full and thorough examination of the patient should be done. Vital assessment should be done, especially of the BP. Both sitting and standing BP should be taken. And if the peripheral pulses are reduced, take lower limb blood pressure. And assess for any signs of dehydration, as natriuresis can occur in high blood pressure situations. Assess for any heart murmurs. Look for any S3 gallops. Look for signs of peripheral edema. And also assess the JVP. And assess for the auscultate for any basal crackles, look for any signs of tachypnea, and look for any signs of altered mental status or any focal neurological deficits, and do a fundoscopic examination if you are suspecting any retinal hemorrhages or any malignant hypertension cause. So workup of the patient, send a CBC, send us a complete urine analysis to look out for any proteinuria and hematuria. Send us creatinine and blood urea nitrogen. Send for the cardiac biomarkers, urine toxicology screening, GRBS, LFT, serum electrolytes, ECG, 2D echo, and also look for a ask yourself three things. So, are there any signs of any organ dysfunction? If yes, manage it as hypertensive emergencies. If there are no signs of any organ damage, manage it as hypertensive urgencies. So, how the second question you have to ask yourself, how quickly you should reduce the blood pressure. Third question you have to ask, what is the BP target during this management. Fourth question is, how should that goal be achieved? Like what medications you have to use to control the blood pressure. So in hypertensive urgencies, the cutoff of lowering the BP is controversial and should be decided upon the condition of the patient and upon the condition of the patient with which he is presenting to us. Then the BP should be reduced gradually over hours to days, and it should not be reduced within a span of like few minutes or hours, because it may cause ill effects rather than the good effects. फिर short term goal should be BP should be reduced less than 160 by 100 in the first few hours, with MAP not lowering less than 25% within the 24 hours. MAP should only be reduced up to a maximum of 25%, not more than 25% basically. So there are only two conditions which actually require a rapid reduction of the BP. One being aortic dissection, which requires prompt reduction of the blood pressure with a target of less than 140 by 90, and second being a hemorrhagic stroke, which requires a target of less than 140 by 90 within few minutes. I mean within few minutes to hours. So if the patient present to us as hypertensive emergency, and if the patient is already a hypertensive, ask if he have missed any recent medication, or if he have stopped any medication, or if there is any new medication which have been incorporated into his medication schedule. So re-administer the medication which he is already using. And if the patient is a new hypertension patient, so start him on new anti-hypertension trial, and considering the risk factors and also the duration and the adverse effects of the treatment. So what is the medication we prefer for hypertensive urgencies? So the first medication which we prefer is levotalol, which is 200 to 400 milligrams. Second being amlodipine, 5 to 10 mg per oral. Third being clinidipine, 5 to 10 mg same per oral. Third being clonidine, 0.1 to 0.2 mg. Captopril, 12.5 to 25 mg. Diltiazem, 100 to 200 mg. And prazosin, 1 to 2 mg. Among these we prefer levotalol, amlodipine and clonidine. So coming to the management of hypertensive emergencies. So the first and the foremost medication which we use for the management of hypertensive emergencies is IV levotalol, 20 mg, which is injected slowly over 2 minutes, and it can be repeated after every 10 minutes if the BP is not coming down, up to a maximum of 200 mg. So basically levotalol is an alpha and beta adrenergic agent, adrenergic blocker, with a rapid onset of action which is less than 5 minutes usually. And levotalol is preferred in all the cases except few. Nitroglycerin, NTG, which can be started as an IV infusion, 5 to 25 mcg per kg per minute, which can be given as an IV infusion, which is preferred in acute coronary syndrome and in patients presenting with acute pulmonary edema. Third being isosorbide dinitrate, started as an IV infusion, 2 to 20 mg per hour. It is also preferred in ACS patients. Hydralazine, 5 to 10 mg IV, which is given slowly and can be repeated after 20 to 30 minutes, and it can also be started as an IV infusion with 0.2 to 0.3 mg per minute. So hydralazine is an arterial vasodilator. Nicardipine, it can be also started as an IV infusion at 5 mg per hour. Nicardipine is a calcium channel blocker, and it is also preferred in patients with kidney disease, or it can be also used in patients with impending MI. Ismolol, loading dose should be 80 mg IV, over which is given IV over 15 to 30 seconds, followed by infusion 150 mcg per kg per minute, and it is usually used in perioperative situations and in patients presenting with tachyarrhythmias. So ismolol is a cardioselective beta blocker. Last being sodium nitroprusside, started as an IV infusion, 0.3 to 1.5 mcg per kg per minute. This sodium nitroprusside is a potent arterial and venous dilator and has an immediate onset of action. So this sodium nitroprusside should be avoided in pregnant women. So this is my presentation for hypertensive urgency and emergency. Hope I did not bore you people a lot. Thank you. So any questions?
What are the anti-hypertensive drugs that we need to be careful about in MI? Like patient is having active MI, is ending in MV failure. Which one should we avoid and which should be more preferred?
So the most preferred agent in myocardial infarction is NTG, because it is a potent vasodilator, and it is preferred in all kinds of MI except inferior wall MI, because inferior wall MI requires more blood flow to the heart rather than to decrease the blood flow to the heart.
Suppose patient presents for emergency. What time could be, how can we estimate when he's going to have an emergency?
So initially you have to treat the patient as hypertensive urgencies and assess for any signs of end organ damage. If there are any signs of end organ damage, with the investigations, you have to treat the patient as hypertensive emergency if the patient present to us as hypertensive urgency. Yeah, so the next presentation will be given by Dr. Mahek Fatima.
Thank you, Dr. Amaan. So, hello, I'm Dr. Mahek, currently a doing fellowship in obstetrics and gynecology in Fernandez Hospital. So I'm here to speak about the gynec aspect of this. Before we even go to why we're doing this, is because in our setup what we are seeing is at least 5 to 10% of the women who are coming pregnant are coming with hypertension, which is drastic compared to even last year's data. So let's begin. First, let's understand what is pregnancy-induced hypertension. So pregnancy-induced hypertension is BP above 140/90. Here, emphasis on the diastolic BP. Anytime after the age of 20 weeks of gestation. Let's say if it was present before 20 weeks of gestation, we'll call it gestational chronic hypertension and not gestational hypertension. So how do we classify this woman? Is when it should be a BP taken at least 4 hours apart twice. Okay. So before we go to this, let's understand the burden that we have right now. 5 to 10% of all women presenting pregnant have gestational hypertension, which is contributing to 15 to 20% of our maternal mortality, which is one of the very great factor. Let's say 88 out of 1 lakh live births end up in maternal mortality. So it increases the perinatal risk by 2 to 3%. Why do we have such a big burden? Is because obviously now people are not going to doctors for everyone's a doctor. They sit at home, finish, come back at TIFA scan. So that is around second trimester, right? And nutritional deficiency is very common in our country, especially in our area, because of let's say religious sentiments of wearing burqa. 90% of the women, at least that I've seen in this area, have calcium deficiency, because of which they have the higher risk of developing pregnancy-induced hypertension. So let's go back to the types of pregnancy-induced hypertension. We have first two spectrums. One is gestational hypertension, which is 140/90, without any signs of proteinuria or any other symptoms, just plain gestational hypertension after the age of 20 weeks. So this is the milder version, can be managed better. Then we have the other end of the spectrum, which is chronic hypertension. This is before the gestational age of 20 weeks, and also it can be before the pregnancy also, and it continues even after 12 weeks of postnatally. So then we have the severe versions, that is preeclampsia and eclampsia. So what is preeclampsia? Preeclampsia is same gestational hypertension with evidence of proteinuria. Proteinuria of more than 300 grams in 24 hours. Let's say patient has just proteinuria, no other symptoms. We classify this patient as preeclampsia. What is eclampsia? Eclampsia is when all the symptoms of proteinuria is present, but patient has developed seizures. Then we classify them as eclampsia. This is the most severe form, including HELP syndrome. So let's go to the pathophysiology. Just like how Dr. Amaan said, everything including endothelial dysfunction because of pregnancy that causes anti-androgenic factors can cause pregnancy-induced hypertension. Besides that, there's abnormal placentation. Let's say tophroblasts have not properly implanted, like there's incomplete spiral artery remodeling and all of that. Then there can be pregnancy-induced hypertension. Even till today, we don't really actually know the basis of why pregnancy-induced hypertension is happening. Okay. So how do we identify high-risk pregnancies? before we even get into people developing pregnancy-induced hypertension, we have some risk factors. Maternal age above 30 is considered high risk. Previous history of eclampsia, preeclampsia, pregnancy-induced hypertension is considered as high risk. There is women who have family history of hypertension, high risk. Then previous history of, let's say, calcium deficiency, obesity before pregnancy, all are risk factors for pregnancy-induced hypertension. So now we have signs and symptoms. So first of all, symptoms, patient can have no symptoms to very severe symptoms. No symptoms would be, patient would be just normal, having BP above 140 constantly, 4 hours apart coming, we classify the patient. Let's say severe symptoms like headaches, blurring of vision, epigastric pain, proteinuria, which we will obviously see with a dipstick. Besides that, nausea, vomiting, and very like tiredness in the late pregnancies, all this can be considered as the clinical symptoms. See, clinical signs would be obviously the blood pressure that we do, the dipstick test, and also now it's become mandatory for us to check the LFT. LFT because there can be evidence of increase in SGPT and SGOT in early pregnancy. That could be a marker for patient developing preeclampsia. Okay, so now we have therapies. Patient has no symptoms, just comes to us with high BP. Then what we do is the patient is put on labetalol or nifedipine. Labetalol being the first line of drug. Second line of drug is nifedipine, which is a calcium channel blocker. And like my colleague said about hydralazine, this is only limited to pregnancy. Hydralazine is not used in any other place in hypertension. Then we have methyl dopa. Methyl dopa is a centrally acting alpha antagonist, which is used less in our setups. Monitoring, when we are giving monitoring for, we are giving antihypertensives for women, we have to monitor their, obviously the BP, we have to monitor their urine output because they can develop oliguria. Then we also have, we have to monitor their reflexes in case we are giving magnesium sulfate. So the next thing we have is the big thing that's called as preeclampsia that could scare even a very, reputed obstetrician. So there can be mild preeclampsia. When do we say it's mild? She doesn't have many symptoms of like no HELP syndrome, proteinuria is less than 500 mg per, there's no evidence of kidney damage, there's no evidence of, let's say, oliguria, then we classify it as mild. What we can do is ask the patient for bed rest, start her on a labetalol, low dose aspirin, and we can ask her to come back for induction of labor at 37 weeks. We wouldn't prolong the labor more than 37 weeks. Then there is severe. Severe may we have to see what's the gestational age. Now how do we classify it severe? Patient has developed HELP syndrome. Patient has proteinuria more than 500 mg per 24 hours. Patient has, but patient hasn't thrown a fit yet. So this is still preeclampsia. So let's say gestational week is less than 24 weeks, we can still terminate the pregnancy. If it is 24 to 32 weeks, we have to assess whether she's in shock, whether she has fetal distress, pulmonary edema, developing eclampsia, thrombocytopenia. That's basically criteria for HELP has to be seen. Let's say she doesn't have any of that, then expected management. Same way, we have to do daily fetal monitoring, give corticosteroids for lung maturity. In case she has the seizure potential, then magnesium sulfate, and then we deliver her at 37 weeks. If she's more than 32 weeks, then we have to induce labor. Because at this gestational age, we can manage the fetus being low birth weight, we can shift to a neonatal ICU and it can be managed. So we'll give magnesium sulfate then. So magnesium sulfate we can give in two ways. We have IV regimen and IM regimen, which is Pritchard's and Zuspan's regimen. So IV regimen is around 10 grams initially over 10 minutes, followed by 4 grams every minute, and it has to be monitored. Let's say the main thing that we monitor when we are giving magnesium sulfate is reflexes, respiratory rate, and also the consciousness of the woman. Let's say we see any signs of magnesium sulfate toxicity. then we have to immediately stop the infusion of magnesium sulfate, and we have to start with something called as calcium gluconate, which is a rule of 10% of calcium gluconate in 10 ml over 10 minutes. Yeah, so now we have HELP syndrome. HELP syndrome, which is imperative for us with any patient, even hypertensive or not, we have to do a LFT before pregnancy, during every visit. Why? Because patients now can develop hemolysis, elevated liver enzymes, proteinuria, low platelets without any symptoms. So let's say it's less than 32 weeks, we administer corticosteroid, and let's say the patient is stable, then we can monitor the patient or send to a tertiary care center. Let's say patient's condition worsens, then we can deliver. 32 to 34 weeks, we have to first give corticosteroids for lung maturity. Let's say patient is responding to that, and if the condition is not worsening, we can keep them in monitoring, and let's say it worsens, then we can deliver. Lastly, if it is more than 34 weeks, no chance we deliver. Okay. So most important, prevention is better than cure. Before even I go to low dose aspirin, calcium supplementation, women today are having pregnancies even without having optimal health. 90% of the women who come to us saying that we don't have children, do ovulation induction, we'll go for IVF, either are obese, have hypothyroidism, have like hypertension, and calcium deficiencies and all of that. So it's optimum for us to, before even planning pregnancy, we need to have a baseline of the woman's health. Let's say the woman's health is all right, only then we are allowed, and everyone else should even understand that they should not become pregnant, because it's a adverse thing to their life and as well as the baby. And moreover, pregnancy above age of 35 should be grossly discouraged. So besides this, we start women on low dose aspirin. Let's say we have from 12 weeks of gestation, let's say they have previous history, risk factors, and it's cost effective, so we start them on low dose aspirin around 75 to 150 mg based on their BP readings. Then we have calcium supplementation. All women have a vitamin D deficiency. Even if we say they don't, they do. We have to start them on calcium supplementations. Better started off in the second trimester. Then we have lifestyle modifications, obviously, smoking cessation, there is good nutrition and all of that. If they are on corticosteroids, stop it. Finally, we have what are the adverse effects of pregnancy-induced hypertension. One main, which can become chronic hypertension, could remain after 12 weeks postnatally. Secondly, they can have ischemic heart disease. Twofold increase in ischemic heart disease is seen in women with pregnancy-induced hypertension. Stroke, again, they are highly susceptible to stroke. And end-stage renal disease. One thing that's not included here, although very low, is pregnancy-induced dilated cardiomyopathy, which is one of the major risk factors of hypertension in pregnancy and hypertension. Okay, that's about it. Thank you. Any questions for me?
As you have rightly said, that hydralazine does not have any role outside of pregnancy-induced hypertension. Why is it so?
Because it increases the blood supplied mainly to the uterine vessels. So when people who do not have any implication in the uterus, we don't use it.
Have more risk. So, but I have seen some ladies, may not be primigravidas, but they deliver from menarche to menopause in some areas.
Yes.
Especially in our areas, especially Barkas, and I have seen in Bhainsa. Mother is delivering, daughter is delivering, granddaughter is also delivering simultaneously. So what do you have to say on that?
So we categorize any woman above the age of 30 as high risk pregnancy as soon as they come. So what we have to see is we have to increase the awareness of they have to have the resources to raise such kids in the first place. Secondly, poor quality of life, poor health, everything. We have to it's our duty to increase in awareness about these things. I have seen many patients who come have delivered 2 months ago, and now they are asking to be delivered again. Like they are planning to get pregnant, even having lactational amenorrhea. So they want us to find a way where we can induce them not to have a lactational amenorrhea and have children. So this is mainly seen in women who, let's say, it would be very wrong, it would be very uneducated women. And this has to be spread to, it's our duty to raise awareness about this. Because at the end of the day, they'll have children with congenital defects. They'll have children with born deaf, born dumb. And it also comes from the male side. Now that there's new studies that says this changes start in the genetic makeup of the sperms before it starts in the ova. So we have to, it's not only for women, men above the age of 35 also should not plan pregnancy. Yeah, that's about it. Anyone else?
Yeah, ma'am. I have a patient who is preeclamptic. I go and check her, reflexes are okay. I have not started any magnesium sulfate, but there is myoclonus. When I'm eliciting, when I'm hyperextending the gastrocnemius, there is myoclonus. So, do I still treat her as preeclampsia only, or should I change my regimen?
Okay, if she has myoclonus, I would call the internal medicine and be like, please come see, something's happening. Yeah, no, but preeclampsia, let's say she's developing myoclonus, then we still categorize her as preeclampsia. Yeah.
I have worked in Marcus area for nearly 9 years. When I joined as a medical officer of urban health post, total this tubectomy rate was 72, just 72. And our target used to be in 12,000 or 13,000 or 14,000. So how we have to get them in line? So I used to keep Quran with me, and I used to explain to their mother-in-laws or their husbands that what they have to do. Nowhere it is written in Quran that you should stop producing children. It is not written. They say that no गुनाह हो जाता अगर हम बच्चे रोक दिए तो, अगर ट्यूबेक्टमी करा दिए तो. They never follow any spacing methods. Even the natural spacing methods of pregnancy and lactation has failed in those areas. So how do you deal with those type of people? So what I did means I used to daily counsel them. Every Friday used to have antenatal clinics. So in spite of telling them several times, they used to never listen. So I started calling their men folk. I used to make them understand that you have to give rest to your wife, because she cannot always have a production machine. She is not a producing machine. So you should give her rest, and their levels of hemoglobin used to be as less as 5 grams, 10 grams, 8 grams, like that. Never beyond. I have not seen any patient above 10 grams. So how do we refer them to higher centers? If they are less than 5 grams, immediately we used to refer them to higher centers. We used to have ANMs who used to work from door to door, assessing those females. And in many of the houses, even ANMs were not allowed to see those females. So how do you go about it in those areas? So only by just tackling is through their religious leaders. We have to contact them, and we have to say that in every Friday prayers you have to make your menfolk understand that what is pregnancy, what are the damages. Financial damage is always there because they have more than 10, 12, 14. I have seen 14 children also in Barkas area. So we have to contact those religious leaders. They have to preach and make them understand that apart from financial crisis, they land up with the mortality, morbidity to the mother as well as to the unborn or newborn child. That's how we used to deal.
Ma'am, does magnesium has any role like urine output? Do we need to check urine output while giving?
Yes, magnesium sulfate has to be seen, because in toxicity, we also have a decreased urine output even in magnesium sulfate. Often it is confused with the urine output reduction in preeclampsia. because there is urine output reduction even in preeclampsia and HELLP syndrome. So best thing would be to assess the reflexes. Secondly, yeah, that's about it. Thank you. Yeah, any other questions? Yeah, it's also a neuroprotective. So we use magnesium sulfate because of that. Anyone else? Okay. Anyone from the audience, live audience? Okay. So now next will be Dr. Agha Rehan Abbas, MBBS, DA and MRCP. He will be explaining us about novel strategies in hypertension. So, yes. Thank you.
I guess you are all bored to death, and seeing especially my face at the end of it, you are like, "ek ghanta leta hai nahi," but no, I'll try to be as quick as possible. So yeah, until now, what we have discussed, most of us already know. We have been taught in MBBS, and these are things that are happening for the last 30 years. We know what is MI, we know how they present, we know what is urgency, we know what is emergency. Yeah, earlier it was called hypertensive crisis, malignant hypertension and all. Right now we don't frequently use those terms. But today my topic is the novel strategies that we are finding, that we are trying to find, trying to discover, trying to combat the resistant hypertension. Let's see what is resistant hypertension first. So yeah, for any person the goal of their blood pressure is different. I can't put a tag on one person and say more than 130 for you is more than 130 of systolic for you is hypertension, and for the other person it will be different. It can't be the same for two people because their lifestyle changes matter, their their performance in their day-to-day life matters. If you consider an athlete, he can have a heart rate of 43 with a BP of 80-50 and he'll be very peaceful. He'll have no signs of cyanosis. But if you see a same guy who is who has a desk job, who is a nighty worker, for example, who smokes quite frequently, his BP while sitting also will be 160, 170 over systolic. He'll be at peace. He'll sleep with that BP. He'll wake up with 210 of BP. He'll be normal. But that is not normal for him. That can be termed as hypertensive urgency. So yeah, lifestyle matters a lot. So we can't put a tag. We can't put one single limit for hypertension of what can be called as hypertension and what can't be called. But as a dictum, more than 140 for any age can be considered hypertension. In order to intervene or not, it depends on their age. If it's a 60-year-old male, up to 160 is acceptable if it's the first time he's having that BP. You don't need to actively treat it until and unless there is under-organ damage. Or else you will be increasing the ischemic penumbras everywhere in the body, as rightfully said by Dr. Amaan. So yeah, what is resistant hypertension? You have used 3 or more drugs. How I like to visualize and remember is A, B, C, D. You've used an ACE inhibitor or an ARB. You have used a beta blocker. You have used a calcium channel blocker, and also including one diuretic. Of all the 3, of the 3, there is one diuretic that is included, but still the BP is sky high, 170 over 170 over 110, 180 over 100, which we usually see in Ardura shower. Majority, and they'll be like, no, this is normal for her. You don't reduce it too much, she'll land up sick. So yeah, the key differential for this will be pseudo resistance, which is caused by poor adherence. They don't want to take the medicine, they won't take the medicine. That's it. They are fixed. Nahi, mere ko aaj nahi khana hai. That's it. No one can change that. So yeah, there is multifactorial pathophysiology and core challenges. The first thing that is responsible for resistant hypertension is sympathetic activity. People are angry, or people are in stress all the time. You can even include this in pregnancy-induced hypertension in male. Wife is pregnant, the husband is having hypertension. That is because of sympathetic overactivity, nothing else. The next thing is volume overload. Subah mein biryani, raat mein peri-peri, dophar mein hospital. All sodium, everything, the limit for sodium is 1.5 grams a day, which is less than one chupti of namak. Literally one pinch. But our people, harne wale pe ek chupti. So that's quite a lot. We need to address that. The third one is arterial stiffness. Because of chronicity of the disease, the arteries are very stiff now. The arteries, they are not plastic, they are very elastic. They are extremely stiff, and the primary barriers to control are, first thing, medicine non-adherence. You prescribe them gorillamycin, they are resistant to godzillamycin. They don't want to take whatever you give them. They'll take one day, the next day they won't take, after the third day they'll feel like taking, they'll take 3. That is the main problem that I am also facing with my patients, and I guess every physician is. The other one is the inability of us to diagnose secondary hypertension. There was one patient that Dr. Chaitanya referred to me, because she was having resistant hypertension. She also happens to be a sister of my acquaintance with Dr. Chaitanya. She was on 4 drugs already, and all of them were from good companies. All of them have reached the ceiling effect. I asked her, what is the issue? Why are you not getting, are you not taking, are you adherent to this? Are you really taking the medicines? She told, yes, I am taking. Do you have any other comorbidities? She said no first. Again I asked. She said no first. But I knew that she is having a craniopharyngioma. She is having a tumor in her brain. She is having a tumor in her brain which is causing her hypertension. So we started cabergoline, and I prescribed her only 2 drugs. One is an ARB and another is diuretic. Right now her BP stays 110 to 130 of systolic, and she is even having her cycles now. She is also having a menses now. So yeah, we have to rule out the possibility of secondary hypertension, which is very prevalent. We as physicians, we can't diagnose it. That's all. And yeah, suboptimal drug selection. This happens quite often. You go to an RMP, he'll directly, write whatever brand he has more margin in. He won't write you what you require. He'll write what you have the best margin in. What we just discussed, adherence issues and ceiling effect. Ceiling effect, it's like छत को लग गया अभी, पानी ऊपर आ गया, उसके ऊपर नहीं जा सकता. Only 80 mg of telmisartan can reduce up to 20-30 millimeters of mercury of your systolic blood pressure. That's it. More than that, it can't. The more you take salt, the more it will keep climbing up. So ceiling effect is reached. Then secondary causes, yeah, this I need to address. Obstructive sleep apnea. We had a patient in Dureshwar, I guess it's been a year or more than that. Just like he was kind of obese, his BMI was 48 at that time. People usually snore in OSA, but this gentleman had cardiac arrest while he was sleeping. And he had such frequent cardiac arrests. In one day he had 3 arrests, and he was spontaneously revived as soon as his airway was opened. First thing, he'll have a snoring episode, then he'll go apneic. Within 20 seconds, he'll end up in flatline. As he goes flatline, the blood supply to tongue and oropharynx will stop. So the swollen organs there, the swollen muscle there will come down, and now the airway is again open. He'll start breathing again. And without performing CPR, without giving him adrenaline, he'll have a normal rhythm again. Within 1.5 hours, he'll again be conscious, 15/15 of GCS. No damage to the kidneys, no damage to the brain. No, he was so accustomed to it. I don't know from what time he's having it. We did a contrast enhanced MRI for him to prove that he is having small vessel ischemia. He had minimal small vessel ischemia. And the reason why he had this was, as soon as he started snoring, I was observing the patient, his BP reached 270/130. 270/130. So that much of BP, that much of blood pressure supplied enough oxygen demand to the end arteries. That's why he was, alive as a medical miracle. Yeah, and now the topic that we are actually here for, emerging pharmacological frontiers, the novel drug classes. Until now, the maximum that we use for resistant hypertension is minoxidil. at the end. If you have given an ARB, if you have given a beta blocker, you have given a calcium channel blocker, you have given a diuretic, apart from that you have given an alpha blocker, you have given clonidine, you have given everything now. Now next what? So majority of the times clinicians are now giving, at least 5 years back, they were giving minoxidil because it had profound vasodilation and all. But right now it is not recommended because it has reflex hypertension. The moment its pharmacological effect weans off, you will end up in way more of arterial constrictions, and it will lead to a lot more of hypertension. So right now we have aldosterone synthase inhibitors. Earlier we had aldosterone receptor and blockers like spironolactone. Now we are stopping it from getting produced. Okay, we are not targeting the receptor, we are targeting the own drug itself. Baxdrostat, it is actually in stage 4 trials, it is being given to the public, but there has only been modest reduction in the systolic BPs of up to 20 to 30, and that too in Japanese population, and their diet is very healthy. They work out a lot, they eat only boiled food, and in them if it is 20 to 30, I don't think it will do anything to our Hyderabadi population at all. Because the level of spices and sodium in our diet is way more than the oil in Saudi Arabia. I don't think it will be helpful at all in India. But yes, dual endothelin receptor antagonists. Earlier we had aliskiren, which was an ETB receptor antagonist. It caused profound vasodilation. Endothelins cause profound vasodilation. These compounds, endothelins, are released from our body naturally whenever we are very relaxed or very happy. These are released when we just finish a workout or whenever we achieve a goal. So that is a time when we usually get these. But right now we are having endothelin receptor antagonists, which is aprocitentan. This is causing profound vasodilatation and it is giving good results, but it is in stage 3. So it's not in stage 4 yet. We need to wait and see how much it will really impact. And there are, earlier we had spironolactone, which is a steroidal mineralocorticoid receptor antagonist or agonist. Right now we are having few non-steroidal ones, which do not have the steroidal complications like developing gynecomastia or having fertility issues, erectile dysfunction and all. So regarding baxdrostat, aldosterone is obviously a steroid, which is it is produced from a steroid, and all steroids are formed by cholesterol. An end product of that will be progesterone. The intermediate will be corticosterone, and at the end we'll have aldosterone. So the reason why we were having the steroidal side effects was because of the production of progesterone. We are not addressing this. We are only addressing the end product of aldosterone. We are only blocking the receptors. But earlier we were not blocking the aldosterone itself, production of aldosterone itself. This synthase even stops it at here. As the name itself denotes, baxdrostat also acts as a statin, which will lower the triglyceride levels as well. So you will be having less progesterone release. Even in men, we do have some degree of progesterone. Even women have some degree of testosterone. Okay, that's about it. This we have already discussed. This also we have already discussed. Yeah, so basically in a diagram I have tried my best to make you guys understand. This is the mineralocorticoid receptor. Okay, we are not targeting this receptor now. We are not targeting this receptor. We are going around the orbit. We are going around it, and we are giving non-steroidal ones so that we don't synthesize these progesterones and androgen receptors at all. We don't go there. We are just stopping it before it. Okay. So yeah, and the interventional procedures that we have developed, but these are also not giving good results. The systolic BPs are only getting down up till 40 millimeters of mercury, that's all, and which is quite less. For patients who have 230, if you give them only 40, even that is less, but yes, these are profound. The first one is renal denervation. Nothing but you pass a probe, you pass a catheter through the femoral artery, you go to the aorta, you go to the renal arteries, and from the renal arteries, they have by neuro, you also need an MRI there, because you need to neuro map it. Wherever there are nerve endings near the emerging and the efferent and afferent arteries, there are nerve endings. So basically these nerve endings will be, they do a ultrasound guided ablation there. You go with the probe, you go near the nerve endings, you give very high frequencies of ultrasound waves so that the nerve endings are damaged. Now there is no sympathetic activity that goes to the brain, and there is no RAS activation. Because of no RAS activation, there will be no vasoconstriction. This is there, but this is giving modest control of systolic BPs, but yes, it is sustained. People are even repeating it twice or thrice 1 year to just achieve that. People who don't want to take tablets. No, I don't want a tablet, just do something. There are so many side effects associated with the tablet. So for them, this is the thing. But yeah, it's not in practice a lot. It's practiced elsewhere, not in India at all. And yeah, this is actually being implemented in India now. Baroreflex activation therapy. Nothing but our carotid arteries, our jugular veins, they have some chemo and baroreceptors, which basically read some chemicals and read the blood pressure readings and give some some signals to the brain and also the arteries to cause vasodilation, to reduce the blood pressure in the arteries by dilating them. Okay. Earlier what happened is that because of chronicity of the disease, these baroreceptors were non-functional because they think it is normal for them. There is no acute change. This only happens when there is acute change. So for this reason, new electrical devices have been, formulated, modulated, discovered, which again is a transcatheter procedure. They are going from the either radial or the femoral route. They are implanting a very small chip which has a lifespan of 6 to 8 months, and it is giving profound up to 40, even in some cases up to 70 millimeters of mercury is getting controlled. But yes, this is still in beta. This is not out for public yet, but in India they are using it. I have seen it getting used in corporate hospitals of Hyderabad itself. But yes, when I spoke to a cardiology colleague of mine, he even told that right now they are planning on advancing this further, so that there is a button which whenever they press, it keeps going down. Whenever they press, it keeps going down. I really don't know how much helpful it will be. It sounds weird to me. Maybe it is not weird for some people, but yeah, you can't give the control to your patient. What if he is suicidal? What if he keeps, what if he is psychopathic? What if he criminally implants it on someone else? So there are many ethical questions related to it, which I don't think will be addressed in India at least. But yeah, companies will make money. This is basically what I just told you. Main thing is optimizing lifestyle and behavioral interventions dash diet. Dietary approach to stop hypertension, DASH dash diet. In this, the recommended at least for Hyderabadi population is less than 5 grams of salt per day. You won't be able to take 1.5. It is impossible. You're not Britishers. So okay, let us make it 5 grams. 5 grams. Recommended is 2 grams. But right now people are saying okay, even 5 grams is okay for you until and unless you take the medicines. If you're not taking medicines, then it's 2 grams. But you can take the medicines and go up till 5 grams max. Okay. Stress and sympathetic tone reduction. Don't take stress. I don't know how anyone can do that. I really don't know. It's impossible. It's humanly impossible to not be stressed and take a breath. It's not possible. Then customized physical activity. We understand that majority of us don't have a lot of physical activity daily because of our job profiles. We do walk around, we do perform CPR, we do, take the stairs while we are going to the upper floors, but that's honestly not enough. Our ancestors used to hunt animals climbing hills. That is what the human body is actually made for. That is what the human body is actually made for. And now if you take stairs in place of elevator and say, no, I really worked out, you're just lying to yourself. You actually have to go to the gym. You actually have to go to the gym. You have to lift more than twice the amount of your body weight. You are supposed to shed more than half of your daily BMR. Whatever is your maintenance, you're supposed to burn more than that. More than half of that, at least in the gym, daily. But yeah, it's not really possible with the lifestyles that we go through, but we should do that. Yeah, in precision medicine, actually this is what makes more sense. In future, I don't think in near future, but in future, we'll have genetic testing. When the child is born, we'll see if he is genetically susceptible to one of the three causes for resistant hypertension, either sympathetic, either volume overload or arterial stiffness. We can develop few tests, and based on that we can suggest them to have one lifestyle. For example, children with autism, they have specialized schools. Children who are very athletic, they have specialized schools. Children who are very smart, they have specialized classes. Similarly, children who are prone to getting these diseases, they can be, force-led into a lifestyle which can reduce their their chance of landing in resistant hypertension. Genetically tailored, basically. Biomarker guidance, again the same thing, and individualized regimens. Leveraging technology. Yes, right now we do have a few watches, a few other devices that routinely monitor our BP, our heart rate and saturation of oxygen in the blood. Well, that looks more of a gimmick to me. It's really not accurate, one thing. The second thing, you'll be more worried of what my BP is every second looking there, and it will cause profound sympathetic overdrive, and you might land up in having more hypertension if you wear that. So for me, it's not the case. For someone else, it might be the case. I don't recommend that to my patients at all, because it causes a lot of phobia in them. It increases the sympathetic tone worse. It worsens it. Patient who I have asked this around 4 years back to wear a watch, he had MI within the next 3 days. He kept looking, maybe he landed in SVT or whatever, I don't know. He had an MI, then he had a stroke and he passed away. Yeah, telemonitoring platforms as well. These devices do give a prompt to us. For example, some Apple Watches do give us a prompt that you have been idle for 40 minutes, stand up, move around. That is what it is. So a robot is dictating your life now because we can't do it. And that's just shameful.
China has already opened an AI hospital.
Yeah, China has opened a AI hospital wherein the robot itself is collecting your blood samples. The robot itself is testing it.
They are treating more than 10,000 patients per day, and they are working 24 hours tirelessly.
Yeah. So that's something that we need to be scared of.
All doctors will be replaced by robots.
Anything can be replaced by robots. Yes, I do agree with that. So summary key takeaways are that there should be multifaceted approach. You can't just focus on one aspect of it, and you can't ignore the other aspect of it. You have to take a thorough. The first thing is history taking. In any case, you have to first rule out the possibility of having a secondary hypertension, which has been the case with a lot of patients that I have personally seen. I have personally consulted them. They have secondary hypertension. They have another cause for hypertension, but it is totally ignored. So the first and the most important thing is history taking. That will lead us to the treatment. That's it. And promising novel therapies like baxdrostat and aprocitentan. Aprocitentan is better than baxdrostat, because baxdrostat it has also been reported that it is causing fertility issues in the rats, because it is stopping the cholesterol from getting converted to the other sex hormones. So yeah, there is that potential side effect as well. If you are worried of prescribing spironolactone to your patient so that he develops gynecomastia, then you need to be worried about this as well. So I don't think baxdrostat will have that long run, but aprocitentan will. I really do believe. And yes, integration is the key. You have to integrate everyone: physiotherapist, your gym mentor, the dietitian, and the doctor. The doctor can't do that alone. It happens in India, but you can't do that alone. It's physically impossible. All right, that's it. Any questions, please?
What is the baxdrostat and everything class of drug for pregnant women?
It's considered very unsafe in pregnant women. It has actually not been given to pregnant women yet, but it was given to rats that were pregnant, and they found that the majority of the babies had features suggestive of anencephaly. Like phenytoin, thalidomide, we might have another tragedy if that comes out. But yes, it is highly not recommended in pregnancy at all. Any other questions?
I have read somewhere that any individual with a basal blood pressure of 80 and 60 diastolic, if a raise of 20 mm of mercury in systolic and 10 mm of mercury in diastolic should be considered as hypertension. Do you agree or no? Disagree?
It's not just about the number. From 80, if you, as you rightfully said, yeah.
But a basal BP of an individual was 80 by 60 suppose, and a raise of about 20 mm of mercury in systolic and 10 mm of mercury in diastolic should be considered as hypertension or not?
Yeah, it depends on who your patient is. If it's a pediatric case, the boy has just grown. Earlier when he was small child, 80-60 tha. Now he is more than 10 years old, more than 14 years old, 160, that is normal. But I understand your question, I'm coming to it, I'm coming to answer it. What matters is the percentage. If you take 80-60, now it is 100 over 60 or 100 over 70, there is a 20% jump. 20% jump is alarming. But what symptoms is he developing? Is it hypertensive urgency, hypertensive emergency? Is he landing in that? Majority of the times, it is not the case. You do a comprehensive health check, you see if there is any other thing that is causing the modest rise, the immediate rise. If there is a diet, if it is because of the stress, it is because of a crash diet, then you can address that and that will be enough. You don't need to prescribe it or call it as hypertension. It might be momentary. But yes, if you have seen the patient for more than 3 visits and he still comes with that same BP reading, and now he says that he is feeling odd, he is having palpitations, any other symptoms associated with it, then yes, then we will call it hypertension and then we'll also treat it. You treat the symptom, you don't treat the guideline. Your patient is more important. What symptoms he experiences, that is more important. Any other questions, please?
This you spoke about the sympathetic innervation, some blocking thing. Yeah. Does it have any systemic side effects? Like while the blood supply to the genitals also comes from the major arteries, then would they have issues with impotence and all of that?
Yeah, to answer your question, good question actually. In this diagram, you can see that you're going through femoral artery. Femoral artery is in close proximation to femoral nerve. Femoral nerve is in close proximation to pudendal nerve. In some cases, what is happening these days is that the ultrasound probe, it is getting activated before you are at your end goal only. So it can cause nerve damage starting from the femoral until your cauda equina. So there have been some cases where, because of the physician error, there have been some cases leading to impotence as well. But yes, as such, there are no gross side effects that have come out of it. But yes, a few side effects, like patient has, because of the procedure, one patient had landed in sepsis because of the blood supply to the kidney itself is usually not affected, because what we are using is ultrasound rays. We are not using electrical rays, we are not cauterizing it or anything. We are using very strong ultrasound waves which displaces the sympathetic nerve endings near the renal artery. The nerve endings are still there, but there is no connection to the renal artery. They are hanging in the coelom or whatever. They are still there, but there is no connection from the artery. There is no juxtamedullary, system that is activated. That is what we are stopping there. That's all.
But eventually it's causing like reduction in water retention, so it's causing diuresis, right?
It is.
Eventually it's causing that.
Yeah, it is causing diuresis, but it is reducing the BP to a normal level. Us as a physician, we have to see what is more healthy for him. If patient comes to me with 140/90 and he says to me that I want to undergo this procedure, I will straightly deny. You don't need it, Baba. You might have more complications related to the procedure itself. This is only for resistant hypertension that is not responding to any of the pharmacological drugs that we have. All right.
I had seen a case, an old man of about 63 years with papillary cell carcinoma. All his surgical aspects were under normal conditions. Even he was a known hypertensive but under control. He had no other comorbidities. During surgery for papillary cell carcinoma, total thyroidectomy with the block dissection of the neck, he had sudden rise of his blood pressure, which went beyond 280 by I think so 170 or 180. Then sudden fall, and the patient landed with coma. How do you explain this? And what the doctor or anesthetist should have done to prevent this type of condition?
No, I was not in that surgery, so I really can't say. Yeah, I understand. I know what you're talking about. I was not there, so I really can't say what really happened. But being in the field of anesthesia, I can say it could have been because of rough handling of the thyroid. A lot of the hormone was released, and because of which he might have had tachyarrhythmia, which actually increased his ejection fraction. Sometimes it decreases when it is too above the level. It increased it momentarily. What happens is that the way you describe it, initially there will be increased amounts of catecholamines and thyroid released whenever there is a vigorous thyroid massage. This even happens with a lot of tracheostomies. We do tracheostomies a lot. This does happen. To my own case, it happened once. What happens is that because of high amount of catecholamines and thyroid hormones, there is diffuse coronary vasospasm that happens because of increased BP. And diffuse coronary vasospasm actually causes reflex bradycardia. So earlier there will be sudden rise in the BP, and within seconds to a minute the patient will land into bradyarrhythmia, hypotension, which is because of diffuse vasospasm. Ideally, if I was the anesthetist there, I would have administered NTG despite the BP, because I understand what's happening with the patient. I would have administered hydralazine or NTG and possibly started another inotropes, preferably ADR along with NORAD, so that we maintain the map and does not cause any higher MACE events.
But they have done everything with their best efforts. Patient landed in coma.
Yeah, mostly because patient had hypoperfusion brain injury. Because of diffuse coronary vasospasm, there was bradyarrhythmia, and the heart could not supply enough blood to the carotids. Maybe that's what happened.
Initially, when the patient was coming back from anesthesia, he responded to pulse. Later, he did not respond.
That's what. Because of a lot of time this happens. Patient sometimes, and it happens because of the efficacy of the drug. I have seen if you take a good paralyzing agent, if you take a good inducing agent, this whole thing does not happen. But if you go to a very good hospital who only thinks about margin and prescribes you and gives you something which is substandard, not WHO GMP certified, then these things will happen. Patient will come out of it and they have a tube down their throat. It is very hurtful. I have had one down my throat. I guess you have also had. You suffered a cardiac arrest once. It's not a pleasant thing. You are scared to death, which will release all the hormones in your body. Everything will be removed at once. Maybe that's what happened. Yeah, even that is, there is a possibility.
That's what I was thinking, that he might have landed the CA.
But within seconds.
To have his CT scan read, but they never did it. Yeah, everything was perfect.
Oh, if there was an IC bleed, then it won't cause a vein bridge reflex within seconds or minutes, like she was saying. If it's so dramatic, seconds.
2-3 minutes, it has drastic fall.
Yeah, it can be because of diffuse coronary vasospasm. It can be. Any more questions? Dr. Chaitanya? So yeah, that was the last presentation, and thank you guys for all being here, taking time out of your busy schedule. And yes, that's it. Thank you.